It is such a joy to be back here on the stage of NextMed after these very challenging few years tackling COVID. So it's really a huge joy spending time with such scholars. So what I would like to try to cover today is the minor issue of prediction in healthcare and where this is leading us. So I'm going to take a bold prediction here, and bear with me. I know that prediction is hard, especially about the future. It's been attributed wrongly to many people, but it is true. I will predict that 2023 is going to be, for most health organizations out there, worse than 2022, and that 2024 is going to be worse for most health organizations than 2023. And why is that the case? That is the case because we have a serious problem of sustainability. It's because we have had some challenges that have been mounting over the time, with the population aging, with multimorbidity, with the rising cost of technology, with the rising demands of EHR documentation that are really making it difficult for our frontline workers, with patient expectations continually rising, and all of this increase in demand is met by a relatively diminishing workforce. Now, that doesn't work well on the long term. And the problem is becoming more and more acute. And the people who stand in the front lines are the ones who are now bearing the consequence. So the problem of burnout shouldn't be a surprise, but this is making it worse for everyone who's staying in their jobs. And this is quite a serious challenge. Now, this is a problem of sustainability. It's a cliff's edge, and we're going there very, very quickly. Our industry is not sustainable, and the only way to change it is not to try to pour more money into the system or to try to somehow train enough healthcare professionals to meet the increasing demand. That will not work. What we really need to do is transform. Imagine for just 1 minute that you've had a gift, that you could look at someone and know that something bad is going to happen to them. Not only that, that you could see an alternative route for them that would take them out of harm's way. Life would be amazing, wouldn't it, if you had that gift? It would change everything, the way that you do a lot of things. It will also change probably how we practice healthcare. Now, this has been alluded to yesterday by several of the speakers. Imagine that instead of coming to your physician with your ailments, with your pain, with your discomfort, with your disutility, they would call you and tell you either that you will have within 12 hours a cardiac arrest or within a year acute renal failure. This would be really impactful if this could be the case. Now, this is not a theoretical construct. The technology is here. Some of you who are aware, for instance, of renal failure know that by the time that this very debilitating condition is already manifested in clinical symptoms, it is too late to make a difference. If you want to make a difference in end-stage renal disease, you need to come early, when the patient looks well and feels well, but is on the way downwards. We cannot, as clinicians in most cases, identify that point in time, but computers can. And they don't need sophisticated omics-driven data to do that. They just need what's out there in your clinical records today. How do I know? Because we created such a model 13 years ago and implemented it on the masses. So the technology is there. If you'll think about it for a second, it only makes sense. None of you treats their car like we treat our patients. Imagine that what you would do with your car is you drive and drive and drive and drive until you have smoke coming out of your engine. When you see smoke, that's when you go to the shop and try to get it fixed. Nobody would run healthcare, would run a car shop like that, but we run healthcare in a reactive manner that is similar to that, and that doesn't make sense. So the technology is here, waiting. The need is urgent, but still, this amazing future that awaits us all is at our fingertips, but in fact, it is not. And when we walk around in healthcare systems around this country, my country, and every other country, this is not what we see in the daily practice. Why? Why is it not the case? There's been a lot of disillusionment from AI. I'm fully aware of that. Some examples were given yesterday. Worsen was one, others. But I think that this disillusionment and this worry that maybe the promise is not real has been premature and wrong. The promise is very real, and it can be realized. The problem, I think, is not even the problem of conservatism. We all work in a very conservative system that is very hesitant to change for good reasons and some that are not as good. But this is not the reason. The reason, the way I see it, is different. The problem is incentives. The systems are not incentivized to change that way. And when you have a strong enough disincentive in front of an executive, this will not change. Yesterday, I think it was Lee Hood that said in the evening, wouldn't it be great to see a future when prevention will be as profitable as care? Well, like in many other instances, the future is here, it's just not evenly distributed. What would a system that would allow this to happen, what would it look like? I would offer the following potential needs. I would say that you would need a system that's big enough to have a critical mass of patients to take care of. That you'd like to have a universal inclusion, so you wouldn't have cream skimming of only those who are most profitable. That you would have in that system a lifelong outlook, so you would need the patient to remain healthy because you are responsible for him or her 5 years from now, 10 years from now, 30 years from now. So it makes sense to invest now in their future. That you would be integrated by design, that you could bridge the silos of primary care, specialty care, and hospital care. That you have enough data, and you don't need a lot. You don't need all the data in the world to make this happen. You can actually do this with very little data. And finally, that you will be willing to innovate. Is there a system like that? Enters Clalit, which is Israel's largest healthcare organization, that cares for over half of the population, 5 million people, from cradle to grave. It gets its money through capitation, and it gets the same amount of money whether you're sick or you're healthy, so you might as well keep your patients healthy. It makes sense. You have only 1% annual attrition. People can move, but they just select not to. And there are 3 other organizations that are competing. It is primary care focused rather than hospital beds and filling those hospital beds, and it's been digitized since the 90s. So we now have at our hands about 5 million lives with 25 years of digital data on those patients cradle to grave. Sounds appropriate for the task? Data is not enough, okay? The issue is not the amount of data you have, but what you select to do with it. So what can we do with such data? This is something we've done about 15 years ago. No need for, advanced AI solutions. We found out differences, in this case, in anemia at the age of 1 year between subgroups within the Israeli population. We identified the disparity, we created an intervention program based on this disparity, and we closed the gap completely, annihilated that unequitable situation. So this is what you can do with data and zero technology. But if you have the data and the technology, you can do things like what I've presented before. You can predict which one of our patients is going to be in 5 years from now in end-stage renal disease, because we can do the predictive models because we have data that goes 5 years back. So we can go 5 years, look prospectively in hindsight, and then say who will deteriorate. That's pretty easy. But it is not a technical thing. It's a paradigm shift from patient level, reactive therapeutics, to population health, predictive, proactive, and preventive in nature. There are many examples. I will give a few today just to explain that this is not a theory. This is implemented at scale on a national level within Clalit. We started doing this in 2015. We have to call every winter and tell our populations, the elder population, to come in for flu shots. But we don't have enough staff to call all of them, so we call only a few. How do you select them? Alphabetical order. So if you have your last name begin with a Z, that's tough for you. Instead of doing that, what we did was to predict who is the most likely to have winter severe morbidity, and then sort the list based on this. So you'd call first who needs it most. This requires the advanced technology of the sort button in your Excel sheet. I'm sure you can all do that. Nowadays, of course, we do this in more elaborate ways, and we add more and more types of data into the mix. Everything that can fit and can be analyzed with more advanced technologies that are from the deep learning domain come to the mix. And again, we will have more and more of that coming in, but this is icing on the cake. This is not a requisite to make this stick. All you need is your EMR data, basically. So when you take this type of data, and you push it into the system, it can, for instance, identify that in your CT that you've done for abdominal pain, there actually is something in your vertebra that suggests that you are most likely to break your bones. I cannot, and the best imaging experienced physician cannot look at the bones and say that, but the computer can. Now, we know that because we've been able to demonstrate it and to show that it actually, this single CT scan can give you information that is equal to all of the clinical information that you can get from the patients in the current state-of-the-art tools that are used for this, in this case, the FRAX. And we compared 3 different systems, and still, CT was better than any and all of them. So this kind of sometimes you want to ask the black box, does it make sense? Is it doing the right decisions? I'll give you one example. When we tried to predict osteoporotic fractures, one of the first things the computer spit at us at the end of the day was, this is strongly associated with eye disease. I went to med school, it was a while ago, I agree, but you know, I've never learned anything about a pathological process that is joined to the eyes and the bones. Not collagen formation, nothing. Why does this happen? Is it a computer glitch? Is it a target leak? What is this? Any guesses? Yeah, if you don't see, you fall. If you fall, you break. It's not that it causes osteoporosis, it's just manifests your osteoporosis in a fracture. So, computer 1, human 0 at this point. But it's okay. Not always we understand how this works, but it works. So, you saw before that it was mentioned that we did not do well in COVID in terms of AI. That is actually, again, not true. AI did not fail everywhere to live up to its potential. This is just one example. As early as March 2020, before we had only a few cases in Israel, we already created an anticipated predictive model for severity of illness of COVID-19 patients. And we called individual phone calls for 200,000 highest risk population of Clalit, each and every one of them. We tracked it. I know, it's 99% that got the call. And we told them there's a new disease, it's called COVID something, stay home. And the impact on eventual morbidity during that first wave was just amazing. So this can work. We then improved the model with data. First of all, we created a I'm sorry for the Hebrew, but we created a simplified model with points, that you get a specific number of points for any illness. You collect the points together, and you know if you're at high risk or not. So if you're at high risk, you can do this at the comfort of your home or in every physician's office, and it worked really well. We could put it on TV. This, I was, at that time, the chair of the National Advisory Team on COVID-19, so my days and nights were pretty hectic, but we used it well, and on national TV you could tell the patients how to do their own calculation and know if they're at risk and act accordingly. So it's prediction all the way to the patient. So, by the way, it worked, and we know because we have assessed it, and we have had really nice ROC curves eventually to show that this works. Later on, we improved the models and used them to decide who gets Paxlovid, the treatment to reduce the risk of severe COVID-19. So this was, again, something that worked very well. I will only mention that we used AI in different ways during COVID. Here's another example. In the second wave, we had paucity of tests. We didn't have enough. So we created a predictive model. By now, you'd guess. A predictive model that says, who's the patient who's going to get infected tomorrow? Based on what happens to his friends, his family, the place he lives, his personal traits. It worked really well. We had pretty good outcomes of that model, and the way it worked is that when a patient went into the physician's office and said, I have stomach aches today or back pain, the physician said, yeah, that's okay, but my computer says this is an alert that actually appeared on every one of our screens for several months with such patients. Maybe I want to ask you a few other questions like, do you have a loss of sense of smell and taste? This was in real time, and it made a difference. So AI did work during COVID-19. Finally, this was the toughest decision that we had to make based on AI during COVID-19. So we were vaccinating for about a month. It is January 2021. And we had lockdown for over a month. And despite all of this, numbers of severe cases kept mounting higher and higher. So you need to make a decision. Do you open the lockdown? Or do you trust the vaccines and open the lockdown, or are you careful and you wait until you see something different? Now, the reason we knew we had to be careful was we saw a similar picture in the second wave, and what happened afterwards was a huge rise in cases. So when you stop your lockdowns, you could have a rebound, a serious rebound, and one would expect that. So if that would happen now, and we take the wrong decision, we were at capacity. We couldn't add one more patient to an ICU bed. We know from other countries what happened at this point if you make the wrong decision. This is an ICU bed when they didn't have time to take the deceased out of the room because the turnover was too big. For some of us who forgot where we were just a couple of years ago. So we didn't want to get there, okay? This was high risk prediction. So what did we do? We used the methodology that, again, we use again and again in our work, which is creating digital twins. We try to create identical twins that look just one like the other, only different in terms of their vaccination status. So if I have a 74-year-old male, ultra-Orthodox Jewish, that lives in a neighborhood in Tel Aviv with 3 chronic conditions and 4 recent hospitalizations, I couple him at the same day with a 74-year-old male from the same neighborhood in Tel Aviv, again, ultra-Orthodox, with 3 chronic conditions and 4 recent hospitalizations, but that was not vaccinated. So these are my twins. And now I follow them until the unvaccinated gets vaccinated, in which I decouple them, put another, in this case, unvaccinated twin to that point in time, and this is an approach that is called emulating the target trial. It's a way of making causal inference from retrospective data without making serious biases. So to cut the long story short, we had the first in the world assessment of vaccine effectiveness, and it showed us very clearly vaccines work. So we saw that in real time. I want to and acknowledge here all of the people that were involved in this, both from Clalit and from our wonderful colleagues at Harvard Medical School. And we made a decision, open the lockdown. What do you think happened? Numbers went down, thank God. But this was a leap of faith. And I got to tell you, your ability to do prediction on a daily basis helps you during emergencies as well. So we've done it a couple more times, actually double-digit number of times since then, working on different aspects of tackling COVID-19, seeing whether vaccines work, what are the adverse effects of vaccine in the real world, how do they move from within families, are the drugs effective or not. So this actually is very helpful in making decisions on your daily basis. And this is from a couple of months ago in a celebration this is the President of Israel in this case, of this collaboration that we have with Harvard Medical School on doing this on a massive basis and on sharing learnings and co-designing interventions. So this becomes embedded in clinical practice, and we do this for a lot of different conditions, okay? And if you want to know outcomes, here's one. We try to intervene in multimorbid elderly patients, and we identify those at the highest risk of deteriorating. You have here the control group and the intervention group. And then, what happens to the control group? Of course, numbers go high. That was predicted. But among those that we intervened with a nurse and a physician working together to prevent further deterioration, there's actually a decline, and we were able to reduce admissions by 43%. The cost averted in this was more than the cost of the nurses that were involved in this process. This is cost saving. This is the triple win that we were looking for. So what we have been trying to create is what we call a learning healthcare system. Not in theory, not in nice slides, but in the daily work. We define the need, we develop the solutions, we test them in silico. We get a sign-off from the clinicians that it works. We deploy in the clinical settings, and then we evaluate the real-life impact, as I've just shown you. And I'll show you just one more example, and it'll be actually very brief about it. HCV, we now have amazingly effective treatments, 97% effective in doing this. We want to eliminate HCV, but for this we need screening because we know that 50% of those infected are undiagnosed. So we go ahead, and this is the PI over there, Noah Dagan, and we go ahead and we screen the entire population. We identify those at the highest risk with really cool models that identify them, and then we go ahead and proactively approach them. After we approach them, we see that as compared to the normal screening processes that we run, we get a 100-fold number needed to screen lower in this approach than the usual approach. So imagine that you can screen 100 times fewer people and get the same number of those who require treatment. Wouldn't that be amazing? So, what's next? We've outreached those patients using emails and text messages. That's cool, but it doesn't work because physicians are weary and tired, and they do not want an influx of insights that you're going to drop on them in the middle of their 5-minute encounter with a patient. Thank you, but no thank you. Even right now, there's not enough hours in the day for them to do whatever the recommendations are for them to be doing. So is there an alternative? what we've been trying to do in the last 4 years is create an innovative platform that puts all the relevant data for the patient, for decision-making in real time, puts everything together, mix it all together, and goes all the way for the bottom line. A single screen with a crisp bottom line of what they need to get done. So you get both the AI prediction of identifying who is at the highest risk, and you also get the personalized recommendation and care gaps. It's called CPI. And what it does is that every night, all of our patients go through this medical sieve, in this case, and recommendations are made for each and every person that goes all the way to the physician in an explainable AI form they can hover over. And surprisingly enough, the physicians, instead of yelling at us, they're happy. So there is a way. Won a few prizes, doesn't matter. So what's coming next? And with this, I'll adjourn. We will be talking a lot about omics. And indeed, we are now in a process of whole genome sequencing 500,000 patients within Clalit, trying to transform care to, first of all, better, more precision medicine appropriately in order to provide the right care to the right patient the first time. So this is classic for what we think about omics. We think about precision medicine. But what I'm trying to tell you, that this is actually something that can help us with something very different. This can help us with predictive medicine. The actionable genes that already are recognized can be used to prevent future illness. The polygenic risk scores that we can create today can come and augment all of the other inferences that come from every other modality and improve our predictions. So we can use omics not just for precision medicine, but also for predictive medicine. So think about that. Future is bright. I would want to finish up with this following slide that reminds us that innovation is not about technology. The technology that won the highest prize for innovation in Israel last year was the one in which a cardboard was put in the patients at the geriatric hospitals near their beds. And that cardboard had pictures of that patient, not what he looks today, but what he looked when he was young. When he was young and a boxer, when she was young and she was a dancer. And you have that, and when the family comes in, instead of looking at the patient at the bed and how they look like today, she actually looked at who they're actually treating. This reduces burnout, increases the engagement on the family. This is innovation. So innovation is not just about technology. Like medicine, it's all about the human touch. Thank you.
Fantastic. First of all, a huge debt of gratitude to Ron and his team for all they did through the pandemic. That was really impactful, amazing work. And I think you met Leroy Hood yesterday, precision, personalized, proactive, P4 you building that in reality, and you come from Startup Nation. You have this amazing Clalit platform, and you're now working with Harvard and others. What are the kind of abilities to take the now, near, next, what you guys are doing already and showing impact, and the kind of catalyzing that in other systems? In the US, there's thousands of systems, many of them misaligned with incentives.
So I think the first point to make is that you don't need a whole lot of data in order to make this happen. It's really difficult to create the models in the first place, but once you know and identify the biologically important factors that need to weigh in, usually with 5, 10 factors, you can get 80% of the impact. So you can do this in all of your healthcare system, no matter how primitive some of the data collection and aggregation systems are. So you just need to have the right impetus and the kind of a sustainable approach to making this happen on an ongoing scale. And then it can be taken everywhere, and those who are interested to get more insights from what is actually working, please don't hesitate to approach, and I'll be happy to share.
So you'll eventually be able to have like Clalit in a box that can be imported into other systems?
I think so. The CPI system, the Clalit Preventive Proactive Interventions, I think right now we are too busy deploying it and increasing the number of chronic diseases and acute diseases in that. But once we're in a good shape, there's definitely something that will go ahead and be offered globally for every health system to try to implement.
Thanks so much for creating the future. We'll see you a bit later today. Thanks.
Thank you so much.